Okay. Good afternoon, everyone. Apologize for being late. Had a little trouble navigating the crowd in the Capitol. They're there for the lighting of the Christmas tree. And if you haven't been in the Capitol, it's very pretty. Do go through. And I think we're waiting for a couple more. Hey, Miss Carolyn. And I know Darlene Taylor's coming. No. Okay. Yep. Were you over at the Christmas tree? Were you over at the lighting of the Christmas tree? No, I'm just getting in from Columbus. Oh. There we go. Okay.
Sorry, that was Lynn.
Huh?
That was Lynn. I think we're fine. Okay.
Okay. Nope, sorry. Okay.
How are you doing?
Okay. All right. We're a little bit short today. People, both of the doctors on the committee had patients to see.
Yeah, we still got.
Oh, sorry. I'm sorry. How did you get out of seeing patients? But thank you for doing it.
It wasn't easy, but we did it.
Thank you very much. They were from Augusta. I guess they didn't want to drive from Augusta. We'll give them a hard time. So with that and starting a little bit late, we will get started. We have Dr. Joseph. If you'd like to come forward, Dr. Joseph, tell us who you're with and what you do at Emory.
Yeah.
And welcome.
Thank you. Thank you, Madam Chairwoman and members of the committee. I'm Dr. Naima Joseph. I am one of the maternal fetal medicine fellows at clinical sites at Grady as well. Towards me. Do that. Is that better? Okay, excellent. So thank you for allowing me the privilege of speaking with you all today, and happy Thanksgiving. I'm just going to pull up my slides here. Okay, so essentially I'm here to discuss the initiative that we've launched at Grady on addressing the social determinants of health as a downstream mechanism to address the maternal mortality crisis that we face here in Georgia. And it's here we go. Obviously, it's no news to this particular committee that maternal mortality in Georgia is increasing, and that particularly it seems to affect Black women disproportionately, as well as women over the age of 35. And although I'm a clinician, fortunately, the care that I provide in the clinical context only affects about 20% of health outcomes. And really what we've come to understand in medicine is that the socioeconomic factors, such as like where people live and work and their education and genetics and behavioral issues, all kind of contribute more so to their health outcomes than what you can provide, the care you can provide in the clinical encounter. And these kind of conditions are called the social determinants of health, which has been defined by the WHO as the environment in which people are born, live, work, play, and worship. And these are what affect downstream health outcomes, as well as the access to and quality of medical care that they receive. The links between the social determinants of health and healthcare outcomes have been well established outside of the obstetric realm. For instance, in the pediatric literature and the adult medicine literature, it's been associated with improved kind of clinical interventions, improved awareness of resources, downstream improved hypertension control and glucose control and things like that. And so what we've realized is that in the obstetric care that we haven't really provided these empirical links, that they're not well established, that we don't know how to integrate them into clinical settings, and that we don't really know whether or not intervening on these social determinants of health has any impact on maternal and neonatal outcomes. So at Grady, we launched the Social Determinants of Health screen for all women attending prenatal care. And the goal of this project are three-pronged. The first is to implement routine screening and electronic capture of social determinants of health in our antenatal care centers, as well as improve linkages to care. The second is to define and document what the complex needs are of our population. And then also to understand which social determinants of health domains may have a particular impact on maternal neonatal outcomes. In regards to screening, so we launched October 15th, and essentially this is done in clinics by MAs, nurses, physicians. Patients are completing questionnaires, which we've called the Blue Sheet Project, and these responses are being reviewed with them by their midwife or by their physician, being documented in the electronic medical record, and then we've also worked to kind of enrich the capacity of our EMR to provide these to provide the community resources. And this is done at every visit for every obstetric patient. This is what our screening form looks like. The first page is basically an overview of how illness starts long before we are able to diagnose it medically, and that we're trying to address social determinants of health for our patients. And then the next page is the questionnaire, and it has 5 domains, focusing on literacy, food security, transportation, housing and stability, and as well as interpersonal safety or intimate partner violence. And then we have another question asking whether or not these needs are actually very urgent and whether they want to be addressed by a social worker at that day's visit. Otherwise, they're getting kind of referred to community resources. And then as far as using the electronic medical record, in Epic, we have a social determinants of health wheel that basically has all the domains. Green, which doesn't show up that well, but green suggests that there's no problem. The yellow indicates that there was a problem, but now it has resolved. And then the red is the problem that needs to be addressed at that visit. And underneath that red, for instance, in this slide, food would be the issue that the patient's having today. There is a link to a community resource that populates into their AVS and as well as discussed with them in their clinical encounter. To date, we screened 1,622 patients with a refusal rate of only 2.5%. The next part of our project is to, like I said, document what the needs are of our patients. And what we found is that a lot of patients are actually telling us that they don't understand what we're telling them in the clinical encounter, so health literacy seems to be an issue. But then outside of that, sticking to the true social determinants of health realms, that food insecurity, housing insecurity, and transportation are the top 3 issues that our patients are facing with. And then the last part is determine which of those domains is most predictive of adverse outcomes. And this is an embedded study in which we're looking at the cohort of women who have delivered at Grady and who have received antenatal care in our clinics that underwent screening and abstracting the medical record for pertinent maternal and neonatal outcomes. Specifically, maternal morbidity, which is considered a near miss for maternal mortality, as well as infant and neonatal mortality and morbidity data. And we're looking to correlate this with what the social determinants of health responses and needs were, as well as to see whether or not the effective interventions, such as referrals and resolution of these domains, had any impact on their outcomes. So for now, we're here in participant enrollment and screened follow-up, but we hope to at least have the study completed by the end of the year, although this project will be long ongoing. Thank you for your time. I'm happy to take questions, and obviously it's my contact information. I'm sorry, I don't see your names.
Thank you, Madam Chair. Dr. Joseph, thank you so much for coming today. I really appreciate your time. And just wanted to say that I think this is a fantastic study, and I was curious, how long is it going to run for? Do you know? Or?
Yeah. Our goal is to enroll patients for a year, which means that October of next year we'll have our last enrolled patient, and by May of 2021 we'll have the last kind of delivered patient as part of the cohort.
And so you're a fellow just for 1 year, or you're?
It's a 3-year fellowship.
3-year, great, great.
Yeah.
So you'll be able to hopefully publish some of these findings.
Right, yeah.
That's great,
Yeah,
that's great.
thank you.
Well, I really think this is helpful, and I guess I wish we could, get everyone to ask these questions so we could better identify people that are candidates for problems. But
Right.
thank you very much.
Yeah, no, thank you. Thank you for your comment.
Representative Stovall.
Thank you, Madam Chair. The Blue Sheet Project, was this something that Grady developed themselves, or?
Yes, we developed it with the Grady Population Health Team as well as the Population Health Team that's in the department at Emory. And it's a collaboration between both the schools of medicine at Emory and Morehouse as well as Grady. Yeah.
Dr. Ellis?
Thank you, Madam Chair, and thank you, Dr. Joseph, for walking up here with me today. And I have to commend you, too, for making this project work. When I first started seeing those blue sheets in my high-risk clinic, I'm thinking, oh, no, something else to do. But we've gotten really good feedback, and at our last session, we heard, I think, Dr. Barkin, when she was talking about depression and so forth, saying that moms felt that they were never asked about how they're doing. And I'm starting to hear feedback from patients in my high-risk clinic. You know, nobody's ever asked me if I had a hard time getting here today, or nobody's ever asked me if food is a problem. And if you don't ask, you don't know, but really when you ask, you need to be prepared for what you're going to hear. So I commend you for the study. But I have two questions for you. First of all, we've heard a lot about social determinants of health, and I don't think, from my perspective, they're clearly identified or clearly understood. Do you think this is a project that, depending on what we see from the results, could be taken statewide so that many care providers are able to offer a similar questionnaire? And really, it doesn't take that long to do. And the good thing is you're doing it every clinic visit with the patient because things change for them. So do you think it could be taken statewide? And do you think that the social determinants of health in rural areas here in Georgia are going to be different than, we're downtown, than in more metro areas?
Thank you for your question. So first, just a comment on the patients. I'm always humbled by the things that the patients go through just to see me every day. And it's really humbling. They do a lot to get appropriate care. So it's inspiring. As far as whether or not the social determinants in health, I think, can be replicated, that is one of the things that we're looking at because there is not a lot of data to see how best to integrate this into practice. But as you said, the workflow is very quick. Providing referrals is very quick. Patients seem to really appreciate it. It improves their satisfaction with their visit. And so I'm hoping that once that we'll be able to publish our findings on provider burnout as well as patient satisfaction and use this as a model to integrate this across the state of Georgia. State of Georgia, I think we all know, is very unique in that it could be an incubator for really innovative ideas and really innovative types of ways that we're addressing the maternal mortality crisis. And I'm hoping that this will lend itself to statewide rollout, as well as improving kind of the linkages that we have as kind of tertiary referral centers with community physicians and community hospitals, as well as like the amazing network of community care providers that are located throughout the state. And then the last is as part of regarding the disparities that we see in terms of rural communities. We know that the MMR doesn't really change across communities, but certainly the causes for pregnancy-related deaths is different when we look at rural Georgia versus metropolitan Georgia, et cetera. And I think that will parlay into what the social determinants of health needs are. For instance, transportation and food insecurity may be a bigger issue compared to housing instability here in metropolitan Atlanta. And so I'm curious to see, as we start to see what our needs are here in metropolitan, it probably isn't super reproducible, but hopefully we'll be able to study that and impact on that as well.
Representative Hughley.
Thank you, Madam Chair. Thank you, Dr. Joseph, for the presentation. I was curious, in looking at one of your charts, 37% had literacy concerns. So how do you all address that?
Yeah, so the question that we ask is how they want to receive the health information. And for those of us that work in clinics, and it's become dominated by electronic medical records, and part of the way to kind of facilitate care is you kind of print out the information with all their information, then you're like, okay, everything we talked about is in this form. And patients, when we kind of dug deep and asked them what this meant, they wanted their providers to actually tell them what was in the paper and like tell them, okay, we talked about your blood pressure, we talked about fetal movement, we talked about labor, just for providers to spend some more time doing that. And that feedback has been communicated with the nurses so that they spend a little bit more time on counseling at the end, as well as with the providers themselves. It doesn't seem to be that they're truly like not, they're all filling out the forms and writing, so it doesn't seem to be truly a literacy issue. And then the next thing is that we are looking at developing a patient navigator program for some of the patients that say that they would like more help.
Thank you.
When you talk about a patient navigator, what do you mean? A person, human?
Yes, a human, yes,
Okay.
Thank you. So in our specialty clinic, we are launching a randomized trial of patient navigators that help patients my clinic focuses on patients who are living with HIV in pregnancy, and to see if having a human who has lived that same experience, who has gone through a successful pregnancy, can help patients attend their clinic visits, understand their medications, improve medication adherence. And so we're looking to see if a model like that can be applied across, especially the high-risk clinics at Grady.
So a peer navigator is someone who's actually had HIV and been pregnant and
Right.
right
And has
okay,
had a
so-
successful
So
outcome.
not just a
yeah.
navigator, not just a nurse
Right,
that
right.
works
Oh,
like
sure.
that, but somebody who actually is living with HIV and has been through the.
Right, and that's the example from the HIV context, but we're hoping to use that across the patients who have had, positive experiences in our clinic and with this program.
I mean, that makes really good sense
Yeah.
in that if you have diabetes and you've had trouble controlling your diabetes
Right.
and all the things that happen in pregnancy, to have somebody who's actually been through that
Yeah, exactly.
would mean a lot more, I think, than just
Yeah.
having a nurse who can,
Right,
know,
who tells
knows
you
the
where to
mechanics
go.
of it
Yeah.
and hasn't experienced what happens in a pregnancy. It
Yeah.
sounds like it's a really good idea.
Yeah.
The other thing I would, we're trying to find things that the state can really do. And we would like to be able to fix all problems. If you, and we have to start somewhere, and in this working on social determinants and the discrepancies between different groups. Have you got some specific things you would like to suggest that the state could actually? All pregnant women are afforded the access to Medicaid. All right. Is it like what we had when I'm on the Rural Economic Council, so I'm going all over the state.
Sure.
And in one place, we had somebody from one of the groups tell us that there were 200,000 children that were eligible to be taken care on around the state on peach care, but they weren't signed up. Now, I find that
Right.
horrible,
That's
that they're actually, we have a program for them there. You should be getting health care, and they're not because they're not signed up. And so we came back, and we discovered that part of the problem is that for the first visit, they had to talk to a live person, and that cut off at 4 o'clock in the afternoon.
Yep.
And there was a 30-page application thing.
Right.
Okay. So that is being reduced to 8 pages. They're working on the accessibility and how long it takes it. And that's because somebody came and presented that out in the hinterland of the rural areas. And we heard that, and I came back, and one other legislator, we all called about it and fussed about it. And so now they're correcting it. Do we have that problem with pregnant women? And if we do, why do they not, when the state provides care for them? What do you find are the reasons they don't sign up with that to begin with, or earlier in the pregnancy and all?
Yeah, thank you for that question, Madam Chair. So certainly the question of Medicaid is tricky. I know that the medical community has kind of called for expanded access to Medicaid in the state of Georgia. But certainly I have run across patients who, despite the presence of Medicaid, have not been able to enroll. And it's very similar to what you found with children, in that the times are really constrictive, the application process is constrictive or restrictive. And so for those patients, actually having someone that helps them navigate through that has been helpful. What I'm hoping to see is that, if there are women whose priority is, I need to get food, I need to have transportation, I need housing, then if we can address some of those issues, as well as perhaps improving the availability of people to help them navigate through that very complex system, that hopefully we'll have more patients that are enrolled in insurance programs. As far as what the state of Georgia can do specifically to address this, I think that aside from Medicaid expansion, it would be helpful to kind of there are state of California, for instance, is doing really innovative things in terms of social determinants of health and pregnancy, in terms of partnering with a very successful tech industry at Uber, Lyft, et cetera, to help people with getting access to transportation outside of traditional kind of cabs or Medicaid vouchers and things like that. So I think that there is room for innovation in that front, and partnering with non-traditional, non-health industries. And so obviously your support, prioritizing this as an issue, and as well as supporting projects like ours, funding, would be kind of helpful in making this program a success.
Can you send me, I mean, has the state of California written something specifically?
I can
on-
find that resource
Can
for
you
you.
find that for
Sure.
and send
Yeah.
it to me, please?
Yeah.
I know that we do have transportation problems and that we do have services for transportation, and sometimes they aren't the best. And
Right.
and of course, in the rural areas, you wonder if they have Uber or
Right.
Lyft in the small cities. But I think that's something that needs to be investigated and maybe a alternative to the transportation that now is being offered if people find that inadequate. But
Right.
that kind of thing.
Right.
The other thing that was suggested at one of these meetings for children was that there's so many services for children that are available, but how you got to them and where they were, that there were so many of them scattered that was a problem. And they wanted a central location. So I asked the new Innovative Health Institute at Mercer, that's a bill that we passed, was it last year, or if that was a project they could do. So they are now doing and putting that together so that there will be one place to go. Are there?
That's fantastic. Yeah.
Is that, would that help if we did it for
Yeah. So the
pregnant women? You think that would, especially in the rural areas or single physicians and all, would make it easier to for people to find the services the state already offers?
Absolutely, that would be wonderful. I know I'm currently working with the Institute of Healthcare Innovation and to create kind of heat maps in terms of resources for the metropolitan area, but that needs to be brought into the state of Georgia, absolutely. So,
Of course, I don't understand why, if you signed up for Medicaid and you're pregnant, why you couldn't just go ahead and sign up. Why you wouldn't automatically be signed up for WIC
yeah,
and some of the other
right.
programs? It seems like to me, and
It should all be.
it all should
the
be,
same
if you
system.
do for one, that automatically you're eligible for that, and that we should take away that.
Right. And at the same time, if you're pregnant and you're signing up for Medicaid, then you know they need to be seen weekly or monthly. Like that should automatically be done and provided for them. Transportation, scheduled transportation, things like that would be helpful too. Yeah. So if that were streamlined, I'm sure that would be
A positive thing.
a really
See if I
positive
got it
thing.
here again. Oh, Representative Silcox and Taylor.
Dr. Joseph, along the lines of transportation, I know that when I took the tour at Grady, that they talked about to decrease readmission rates and to improve the efficiency of the hospital and all, that they frequently send out people to follow up. And so my question would be, did you investigate at all sending people out to the patients as opposed to the patient coming in to follow up and to do
No, that's a
follow-up work?
great, it's a fantastic idea.
Okay,
Yeah.
because I mean that's what they talked about.
Yeah.
That, when someone had surgery, and to me, pregnancy can be like surgery, right?
Right.
I mean, you need follow up and reassurance and all
Yeah.
those things. So to me, that would be a way to get transportation is just to go to them.
Right, yeah.
Um,
We currently have a program that we're launching next in January for women who have had like really severe cardiovascular morbidity for home blood pressure monitoring that kind of is electronically sent to us so that we review those reports. But it would be great to kind of send that because all our women are high risk. And so it would be wonderful to kind of have a mechanism where some of the healthcare is home healthcare.
Right.
That's a great idea, yeah.
And second, I guess I was a little confused on Representative Hughley's question about literacy. Is that really they can read
Yes.
the documents? They just don't want to deal with the bulk of
The
it.
bulk
or-
of paper, right? They have a
Okay.
bulk of paper. They don't know how to navigate that, and so kind of going through what the patient instructions are, what to look for, what was reviewed at the end of the encounter seems to be what they were looking for more than not being able to read.
Okay.
Well, in our last meeting, and we had a presentation on a program that's happening down in the Albany area, and then the rural, we were on the rural together, Representative Taylor. Where was that other one that's happening? Somewhere else in South Georgia, where they are grouping women together who would have like interest in all.
Sure.
And they are doing a telemedicine program with them, but also the group meets. And they seem to think that would support and going over different aspects. They go over 3 topics each. and that's done by telemedicine
Oh.
and by
It's like centering pregnancy, but
right,
yeah.
and on the topics of pregnancy, but the interaction among the women and the group as a support group seems to be being very ineffective. They've reduced the rate of early deliveries tremendously, from like way up in the high teens to down to like 5% or something like that, and
Yeah.
from these groups. It seems like, I mean, there are areas all over Georgia where it's innovative, like you said, and hope
Yeah.
to be. We are an incubator, and there are things going, and we don't hear about them, but they are out there. But I think we need to be working on all cylinders to try to find the ones that have positive long-term effects and
Right.
are effective, and replicate those, and from no matter where they come from. Representative Taylor.
Thank you, Madam Chairman. One of the things we talked about innovation in our community, it had been a question getting people to know where to go. If you find you're pregnant, where do you go? I've reached out to our, it happens to be our high school that has a great media program. They're actually writing a public service announcement, which will be on our TV, and we're working with our health department, and the health department is going to be the contact, and they will actually hand walk the mother to the resources that they need. And that has been they're doing the walking part now, but getting the information so the women know where to go. We'll have a phone number and a website, and I think that's a beginning start. A lot of times they just don't know where to go and how to get their resources. And by going through the health department in our community in Thomasville, they're all close together. So they are taking them to WIC, and they're taking them down to where the doctor is also. I think that's something we need to look at, whether we do it. I've actually had other communities ask for it, but you need to make sure that in your community it will be your health department. And I think that is a resource, if nothing else, that's the beginning point to go to. Thank you.
I think our public health department is an area where across the state has been not utilized to its full capacity. And as I said in one of the other meetings, the state doesn't totally run the health department. That each county has a health department and has a county board that runs that, just like we like the county election boards and so forth, that they run the elections and the polling places and stuff. They run the county health department, and that board has a lot to do with what they do. And we're finding that with a county health department in all of our counties, that it is truly underutilized. And I know that Dr. Toomey, the new Commissioner of Public Health, is meeting with the doctors that run those, not the boards, but the doctors that actually run the day-to-day clinics. And one of our high priorities is reducing the number of maternal deaths that we have in the state, and also the infants that we lose. So, and better utilize our health department. Thank you for coming. Thank you for what you do at Grady. Grady is near and dear to my heart. My husband did most of his training at Grady. He's an Emory graduate, and so I'm sort of a big champion for Grady and for all you do and the patients you see. I thought of one question as I was saying that. I was going to let you go. We had a young lady that came to me. It's amazing how many people are coming with ideas and things. She's applied to medical school at Mercer. Hopefully she's going to get in. And she did a study about prenatal visits. And she actually found that there were more women in the urban areas not getting prenatal care. Now, there was a one-year study, and as she said, she now has the data, and she's going to update it for the next year, so she'll have to see if the trend, but than you do in the rural areas, which is just the opposite, which I think most of us think.
Right.
That it would be more in the rural areas not getting prenatal care. Is this a trend you see at Grady, with a large number of the mothers coming in with either no prenatal care or getting prenatal care very late in the pregnancy?
Yeah, I think, and Dr. Ellis, you can correct me if I'm wrong, but I believe that we have about 70% of our patients have had at least one or two prenatal visits in our practice, but we do have about a third of the patients have had either no prenatal care. I'll have to look, I know I have these numbers, but it is quite enough. I've come from, I practiced in Boston before, and it's a lot more than what I'm used to seeing as far as numbers of women that are coming in either late or with no prenatal care.
Do they
Yeah.
give you a reason? I mean, do any of them?
Anecdotally, I don't
Right,
know in a
anecdotally.
systematic fashion, but anecdotally, a lot of the women I'm seeing either are multiparas, meaning that they've, done this before, had kids, et cetera. And so it's kind of, routine. Some women have had issues with either documentation or issues with obtaining insurance. And then a small number, it's not that many, but say that they've had issues actually with scheduling, getting into our clinic. That doesn't seem to be the majority of reasons. So, but what I tend to hear is either, oh, I didn't think I needed it, or, having issues with documentation and legal status, or
I've done it before.
insurance. Yeah. Mm-hmm. Or done it before.
And that's
yeah.
what the young lady found. She did it up to 6 babies.
Yeah.
And how it dropped off. She also followed
that's
that about,
fascinating, yeah.
how many people that were on number 6 baby
Yeah.
don't come in for prenatal
Right,
care. I think they probably would say, I've done this before
Right,
and I can do it. Although, I don't know, after 6 babies, you could be at a higher risk.
Right. Mm-hmm.
And needing that. But thank you again for taking
Absolutely.
time to come and talk, and we look forward to, you can let us know again, and maybe we can get you back to when you have
some
the
more
study
data.
published. When will it be done?
2021.
2021. Okay,
Yes.
thank you very
It's
much.
my privilege. Thank you.
All right. Okay. I have Lexi Dunn and Kate Wilbur, both PhDs, academics, out in the workplace, but working, not in academia, I hope, or not all the time in academia. You work too? Okay. Not that academia is not work, but I mean, you're out seeing patients. Need to go back from that. So anyway,
It's okay.
Make sure it's working.
there we go.
Thank you.
Thank you for
We're
coming.
gonna move it back and forth.
Okay.
Yeah,
And Eileen's our.
it's a team. It's a team
All right.
effort. Yes, I'm Kate Weber, and we want to thank you so much for all the time and care that you're putting into these committee meetings and for allowing us the chance to speak. I've been a midwife for 20 years. I've been teaching midwifery for a decade or so, and I'm here on behalf of the Nurse Midwives of Georgia.
Now, that's the nurse midwives,
Yes,
right? Certified nurse midwives with an
Certified nurse
UNRN.
correct.
Okay.
Yes, and Lexi will.
Okay.
I'll talk about that a little bit more.
Okay.
But my name is Dr. Alexis Dunn. I'm a certified nurse midwife and an assistant professor at Emory. I started off as a labor nurse, and then I became a midwife. I've been a midwife for 10 years, and so we practice a little bit, but we are mostly on the educational and research side now. So.
Okay.
All right. Uh-oh. I guess we went down.
You okay? Okay.
It just went down. It just went down.
I don't know.
I'm having a senior moment. Yeah, just having a senior moment. You know, the nice thing about having all the OBs and the nurse midwives is because Tara's pregnant, and I keep worrying about, if this, we might have to have a delivery here.
We got it. We got her covered.
She keeps reassuring me it's not until the end of February.
Not till February, no.
I like February. My birthday's in February.
It's a great month.
Is that a good month?
That's like the best month.
Well, yeah, because the third trimester is when the colder months
Right.
tends to be better. You're looking at a professor that taught OB once. That was enough for me. It was only in an emergency situation, I can tell you.
Right.
Peds and
Orthopedics,
Yeah.
cardiac.
yeah, no, pediatrics and psych were more my areas, and they were my areas, and we just had a faculty member go out at the last minute and due to medical reasons, and there was nobody to be had. So it's
You
like
just had to do it.
me.
I'm sure you did a great job.
Except I had to have somebody help me in labor delivery.
Oh, we're ready to go. Okay. So we already did that slide. You can advance. So what is a certified nurse midwife? So we are advanced practice registered nurses, and we specialize in the care of women who are mostly healthy or who have stable health issues. And we take care of women across the lifespan. And in the next few slides, I'll kind of explain to you what that looks like. I think that families really appreciate us because we spend a lot of time with them. We have a holistic approach, and we spend a lot of time doing education and health promotion and prevention of complications and unnecessary procedures. And obstetricians like to work with us because, well, one, the patients really like us, but two, it allows them time to focus more on the high-risk complex patients, so we can take care of the more low to moderate risk. So it really works out in a very good collaborative fashion, yes. You can go forward. As far as our training and education, so before becoming a certified nurse midwife, you do have to become an RN first, and then you go back to an accredited midwifery program to obtain either a master's or a doctoral degree. And so after you complete that degree, which is through accredited programs through the Accreditation Commission for Midwifery Education, which is recognized by the Department of Education. Once you complete that, then you go on, and those programs last between 2 and 3 years. You go on to complete a board exam, which is offered through the American Midwifery Certification Board. And so once you pass that exam, you are able to practice in all 50 states, Washington, D.C., and all U.S. territories. You just have to pass the exam. And so after that, recertification is every 5 years by either retaking the board exam or you have to complete the educational modules, and I choose to do the educational modules. So as I said, we practice in all 50 states, DC and US territories, and compared to medical education, training for midwifery is much more affordable. It's a cost-friendly option. So this slide, I know you probably can't see it if you're looking on the screen, but as we try to figure out how to solve the maternal mortality crisis, I think we have to really look at different specialties and their role on the team. So we know that the systems with the best outcomes are where you have an integrative approach where everyone's working together. So we see ourselves as nurse midwives as part of that continuum of care. And we provide a distinct type of service where it's holistic and very interpersonal. So the first column describes the care that women receive from our physician colleagues. So I won't go heavily into that because I feel that we're really clear on the role of OB and family practice physicians, but I kind of want to focus a little bit on that middle column. So advanced practice nurses, as I've told you, are graduates of nationally accredited educational programs who complete a national certification and who are licensed in all 50 states. And so you're an RN with a master's degree at minimum, or you can go on, like Kate and I went on further to complete doctoral degrees. And there are also some nurse midwives who do dual training where they can get additional certifications, such as, to get the FNP, the family nurse practitioner, or the women's health. So after you complete your certification with AMCB, we go into practice. And so we are trained to provide care in 6 key areas. So we can do primary care for women, women's health and GYN, and then the pregnancy-related care. So that's the antepartum, intrapartum, and postpartum care, and then newborn care up to the first 28 days of life. And so we're skilled in normal birth with women that are of low to moderate risk category. And so right now in Georgia, there are about 500 or 550 nurse midwives. And according to the data that we keep, we attend about 20% of the births, but we think that it may be more because the way we capture data doesn't always capture it well. But the data that we have available says that it's about 20% of the births. As far as our birth setting, 95% of the certified nurse midwives in Georgia are in the hospitals, but there is a subset that's practicing in the birth centers and doing home births. So right now in Georgia, there are 3 birth centers, 2 of which are midwifery-led, and that's the Atlanta Birth Center and the Savannah Birth Center, and the third one, I believe, is in Macon, is physician-led. And so of that, you can see we practice across a wide range of settings. The other practitioner you may hear about, I'm sorry, you had a question? Okay. So the other practitioner
you may hear about is the women's health nurse practitioner. And so they provide primary and maternal care, but they don't do deliveries. And so there are also other members of the team. So we have skilled independent midwifery practitioners that do not include the nursing scope.
Not in Georgia.
Not in Georgia,
Not
but
in
in
Georgia.
general. Just, you know, I didn't know what you all had been hearing about. And so they too complete an educational program using an apprenticeship model and practice out, you know, in more of the home birth settings. So, and doulas are also professionals that you may hear about that are an important part of the team. And they provide, they're not obstetric care providers, but they're a part of empowering women, educating them during pregnancy and afterwards, and promoting child.
Yeah, we're really not,
breastfeeding.
this is not about levels of practice. This was about, you know, care and reducing maternal.
Right, right. I was just
Mortality.
trying to share with you, like you might, well, I know I've been hearing about all these different people that are on the team. So our focus is about nurse midwifery, but just
Okay.
kind of the different people that touch on what we do, or
Okay.
people that we've been involved with. So you can go for it. So as we continue to address maternal mortality, I think we have to understand that different women need different choices. And so sometimes I think we look at equality as trying to give all women the same access and the same things, but we have to kind of shift and look at health equity, which is giving them what they need to achieve optimal health outcomes. And we feel that nurse midwives are one of those resources that can be provided to women to help them to achieve health equity. Additionally, as we've talked about, there are social determinants of health and racial disparities in a lot of the perinatal health outcomes. And so I refer to, I don't know if you all know of Dr. Kamara Jones, if you've heard of her, but she's a family practice doctor and an epidemiologist. And she has this analogy about plants and flowers where she says that you can't just look at the plant and why it's not growing or why it might be dying, but you have to kind of consider the soil that's around it. And so when you talk about the social determinants of health or the healthcare system, you have to kind of consider those factors in as we talk about the causes of maternal mortality. So as nurse midwives, we care for women across their reproductive lives. So the way we look at it is women and families are at the center, and we're kind of on these four spokes on the outside. So we care for women before and between pregnancies by offering family planning services to help prevent unplanned pregnancy, by providing preconception education, which is very important for their health as well as the health of their babies. We also see them during pregnancy and offer traditional prenatal care as well as something called centering. I'm sure you've probably heard about that, but that's more of a group-focused prenatal care. And it's been shown to decrease rates of preterm birth and increase things like breastfeeding, and so it has been associated with good outcomes for women. And during labor, we try to aim at minimizing the use of interventions and really trying to promote a natural path for women. So we reduce the risk for cesarean, which, you know, once you go into the cesarean realm, then you increase the risk for hemorrhage and blood clots and things like that. So we have an initiative called the Primary Cesarean Initiative, or Reducing Primary Cesarean Initiative, which is aimed at promoting normal physiologic birth. And then we also follow women postpartum. There are models where we do home visits, where we go and see women after they have the baby, and we know that the latest data shows that many of the women who are dying in Georgia are dying in that postpartum period. And so what I'll do now is turn it over to Kate, who will kind of talk more about CNM care and how it could be beneficial.
Okay, and can you relate this to where you're working? Are you, because that's what I thought you were
Where?
coming to prepare.
Okay.
In,
How this relates to where I work. Okay, so I have a lot of jobs, but my primary job is as a professor.
Right.
And so I'm the only professor of color at Emory. And so I'm able to, in the midwifery program. Let me
Okay.
say that.
okay, all right, I thought, okay.
In the midwifery program. And so I think by being tightly tied from a, I can relate to this maternal mortality. I feel like I bring a perspective that helps to train up that workforce and give that lens. But I also work as a clinician in two places. I work as a per diem midwife at Northside, which is one of the busiest hospitals in the country. And that group is a group of obstetricians, maternal fetal specialists, and midwives. So that's a really high-risk population. But I also do work at the Atlanta Birth Center, which is
Okay.
the low risk. And I'm kind of learning more about the holistic care of women. And we do a lot of care, education about sleep and diet and nutrition. And they do a lot of group-focused prenatal care. So I'm kind of
Seeing
doing
both aspects of it.
right,
and that's-
because I'm training people, so I feel like I kind of need to understand both. But most of my background is in the hospital, kind of high risk setting.
Okay, thank you.
Okay, so we've already talked about the social determinants of health, so in the interest of not belaboring, Under the maternal health system column in the red, where we think midwives can make the biggest difference is in the risk-appropriate care. Risk-appropriate care, patient-centered care, and certainly we know that our care is high quality by all the data that we have on it. I think we skipped one. That's okay. No, we go back to the last one. That's it. That's fine. To look at how midwives can eliminate preventable maternal mortality in Georgia, let's just focus on the C-section rate for a minute. We think there are other roles that we can play besides this, but particularly the C-section rate. We've talked about other complications and causes of maternal mortality, which you can see on the top of the slide. That's from the Georgia Maternal Mortality report that came out this year. C-sections, according to the Center for Medicare and Medicaid Services, increase the risk of maternal death by 8 to 10 times. So C-sections matter a lot, and it's something that we need to focus on. It doesn't cause a maternal death directly, and certainly I should back it up and say C-sections are life-saving procedures that we absolutely need. I had C-sections, like we know that they're important, but when you have too many of them, you're increasing risk without getting a benefit from it. So if you look at the causes of maternal mortality, you can see that those boxes underneath, embolism, hemorrhage, and amniotic fluid embolism, those are increased by C-sections, and those are causes of the maternal mortality.
Well, how are you saying, as a certified nurse midwife, that you're going to decrease the number of C-sections? Are you saying that you make the decision early on, supposedly in conjunction with the physician, that the person doesn't need a C-section?
No.
Or how in the labor and delivery process do you actually prevent, as a certified nurse midwife, the need for a C-section specifically?
Right.
I mean,
so there are a lot of things that we do differently in labor that can maintain a healthy labor and not increase risk. And generally that is through the judicious use of interventions, as Lexi was starting to talk about. This is not exactly where I was going to go with this. So doing things like intermittent monitoring instead of continuous monitoring. This seems counterintuitive, but we've known for 30 years now that intermittent monitoring in labor reduces the C-section rate without hurting babies.
intermittent?
Yes. To listen periodically allows women to be up and on their feet, mobile during labor. That helps move the baby down through the pelvis. It keeps the woman off of her back, which can be bad for her circulation, which means if it's bad for her circulation, it's bad for the circulation through the placenta to the baby. Does that make sense?
Okay, wait a minute. I'm going to go back. And I'm not trying to give you a hard time. I'm trying to understand. You're saying intermittent? Or
So you can listen
which
to
one's
the baby
which one's better, continuous or intermittent?
It depends on your patient.
No, okay, but
So
which,
for a low-risk person who doesn't have an epidural or Pitocin or something like that, that would mean that you would want to listen more continuously. Intermittent monitoring is safer.
okay.
It reduces her chances of having a C-section without increasing any risk to the baby.
And that would be because a baby's heart rate is going to drop at different times during the
There
labor.
are a variety of reasons. And I think the midwifery care is not just the intrapartum component. Yes, we manage labor a little bit differently, but I think it's the care that we provide to women preceding delivery. So we are much more educating them about nutrition and stress. And, for instance, at the birth center, we have everything is right there together. So you have like a chiropractor is there. You have nutrition specialists that are there. So if we check something, let's say vitamin D levels, which we know that low vitamin D can be associated with a variety of outcomes, we refer them and we have a nutritionist that can come counsel and spend time with them talking about things that they can do to optimize their health. So by the time they get into labor, we are, one, not rushing to inductions. We're trying to allow for time for them to naturally go into labor. And two, and inductions is a big contribution to the C-section rate.
What is?
Induction of labor. So
okay.
if you are putting a woman into labor before her body's ready, you're going to increase the risk for C-section. So I think that midwives do a better job as far as really trying to counsel women to be patient, counseling them on signs of labor, and really allowing the body to naturally do what it's going to do. And then once you get into labor, we're not so quick to start Pitocin or to like just start doing things to the women. We try to allow the time to let them progress through. And so with that being said, it naturally is going to reduce the C-section rate.
Okay, so what you're saying is it's more of an overall health issue of care that goes on even before labor.
Before pregnancy, but
Well,
yeah.
if you can get them before pregnancy, but rather than an intervention. And the way you said it, it sounded like you had some kind of something right there in the labor process that was going to keep somebody from needing a C-section if they, that kind of thing.
We're not trying to keep people from having a C-section. We're trying to make sure that the right people get a C-section and that people who don't need it don't get it. And a lot of that has to do with just allowing enough time.
Okay, got it.
There are specific interventions that, like eating in labor. I was trying to illustrate, I guess, but like eating in labor, it's very typical for hospital policy to not allow women to eat in labor, but there's good data that they're less likely to have a C-section if they do, and that they're much more likely to be struck by lightning than they are to have a problem with eating in labor that would cause them to have trouble breathing. So it's a very old rule that just keeps going.
All right.
But there's not a basis for it. So partly it's those practices, and partly if you just look at the statistics, it's not just the pregnancy care. I think that is helpful too. But if you look at, I'm not even sure which slide we're on anymore, but
Right there, I think.
let's stick with that one for a minute. The overall, the Joint Commission uses as a quality control quality standard the NTSB C-section rate. So it's people who are having their first baby at term. It's one baby and it's head down. And they use that to standardize the comparison groups so that we're comparing apples to apples and oranges to oranges. So if you only look at those women in labor who enter labor in that situation at term, one baby head down, Georgia's overall rate is 28%. When I pulled 3 different midwifery practices, different types of practices, there's the Atlanta Birth Center, there is the Grady midwifery practice, and then there was the practice in Thomasville of midwives. Their NTSB C-section rate was between 10% and 17%. It's a lot lower because of the way they practice.
And the Atlanta Birth Center's most recent data, I think the C-section rate was around 9%. And the preterm birth rate was 1.4% in the latest data. But 98% term or full-term deliveries.
It's not just Georgia data either. The Green Journal, which is the main journal for obstetricians and gynecologists, the OBGYN journal, just showed that if you compare low-risk women cared by different kinds of providers, people having their first baby are 30% less likely to have a C-section if they have midwifery care, and people having any other baby, second, third, fourth baby, are 40% less likely to have a C-section if they have a midwife taking care of them.
And what do they
So
attribute?
we're not looking at high risk when we're only looking at this subset that's where we specialize.
What do they have scientific studies to prove this? What are they attributing? Are they attributing, I would think it would be, this is off the cuff, of having somebody along the way besides the nutritional and good health care and kind of outcomes that you would help promote, would be almost like what we're talking about in the peer group, is the support system that you give and having that closer relationship than you perhaps have with a physician because of the lack of physicians.
Perhaps. They didn't look at who provided the prenatal care. They just look at these women when they enter labor, when they enter care at the hospital.
So they didn't have it broken out and who took care of, who delivered the women.
They just looked at who is taking care of them while they're in the hospital.
Okay.
I think that time is probably the best answer that makes the most difference across the midwives as a group. So different people have different practice styles as far as eating or the monitoring, the other things that we could talk about, but the time is a big factor.
I would think that would be, it's like somebody holding your hand and being there, a private coach.
The support goes a long way.
Yeah,
It does. People contract. There's an oxytocin hormone, the love hormone, and it's hard to feel when you're stressed.
Okay.
And we know that people feel more of that when they feel like they're being nurtured. That's the hormone that makes you contract, that helps you deliver and helps you breastfeed and helps you connect to the baby, all of those things. So we try to create that kind of environment in lots of different ways. Okay, cost savings. Midwifery care costs less, not more. It's a lot of hands-on care, and it's a good deal. So if you compare, let's say we compared on the bottom left, there were 43,000 low-risk Georgia women, those NTSV women, who had C-sections. Of the 43,000 low-risk women Georgia had C-sections, if they had C-sections at the same rate as with the Grady midwives, the amount that Georgia could have saved was over $12 million. If those low-risk women had care at the same rate as the birth center, Georgia would have saved almost $20 million.
You're saying Grady has a higher C-section rate?
They have a lower C-section rate than the state average. They have a really good rate for a hospital-based practice. It's higher than the birth center.
But they also, the birth center really has to risk, like you have to be a certain criteria to be at the birth center. So that is really the low risk women. So Grady naturally is going to take care of women that have a few more risk factors. So it makes sense that theirs would be a little bit more higher.
Okay.
The other way to look at this is on the bottom right. If we increase the number of low-risk births attended by midwives in Georgia, and not talking about C-sections at all, just midwives taking care of as many low-risk people who would want midwives to take care of them. According to the Department of Public Health, I know Lexi quoted 20% before, and that's kind of what we think it is. Department of Public Health said that 13.5% of births in Georgia were attended by midwives in 2017. If we increased that so that midwives were taking care of the 1/3 of women who were low risk to begin with, that would have saved a lot of C-sections, and it would have saved almost $60 million.
Well, since Emory has the only midwifery school in the state, I don't know whether you heard in one of the other meetings, but we are now getting another midwifery program
I'm really
in the state.
excited about that.
So am I.
Yeah.
Especially if they will make it where women in rural areas, nurses in rural areas, that they make it conducive to them coming back
It's true.
to getting their education, not, just kids right out of school and they're going to move on to somewhere else. But if they will get people that are going to go back to communities where they're already living and have a family and own a home and there. So I am too. Is try to make that available so that we have more midwives nurse midwives across our state.
So let's talk a little bit more about how midwives can be better utilized in the state. First, looking at the distribution. So I know you've seen these maps before. The darker areas are the higher density of provider, and the white areas are the areas where there's no reproductive health provider. So the map on the left is midwives, and the map on the right is OBGYNs. So 3 things that you can notice. One is that there are a lot of counties that have neither, which you already know, but I think you knew they didn't have a physician. They also don't have a midwife in most counties. Number 2, you can see that while Georgia has about 550 midwives, the distribution could be a lot better. And 3, the midwife map mirrors the OB map. It's limited, midwifery practice is limited because in areas where there are not a lot of physicians already practicing, midwives can't practice. There's the 1-to-4 ratio of 1 physician to 4 advanced practice providers.
Yeah, I think I'm looking at that already.
It really limits where we can go and what we can do there. All it takes is for the physician who's in those areas to retire or move away, and all of a sudden the midwives have no practice and there's nobody to provide care to those patients.
Well, of course, one of the problems we have is that there aren't nurse midwives there either.
That's true, but they
And
can't be there because there aren't enough physicians there.
Finding that's not what the studies are finding. They find that, basically nurse midwives and PAs and nurse practitioners are not going to go to areas in rural Georgia unless they, have family there or they marry and somebody goes there. They have the same problems that we do in getting physicians. Now, that's one of the reasons why I'm talking about the midwifery school. It's so important to get people that already live there. Otherwise, they will just be educating people just to go back to the metro areas. It's just one of the problems with wanting to live in rural areas.
I imagine too, I wonder, like, if you get them in the rural areas, the competitive nature of pay, like some people want to be more in urban areas.
I'm sure
Get
that
out. So-
pay. Well, and the other thing is that you're dealing with somebody with a master's or doctor's degree, and like this. You're married to an educated person, another professor, or a lawyer, often, and there needs to be a job for them. And I can tell you, in Byronville, Georgia, which is 2 streets, you're probably not going to find that. And so, the quality of the schools. There's no place to go to a play. There's no symphony. There's, and it's the same problems that we're finding with across the lines of the PAs, nurse practitioners, everybody, is that where the physicians aren't, we don't have the other people either, basically. And it's because of the ruralness of the area, how many people there are in the area. We're aging. If you've got these counties and there's only 2,000 people or 3,000 people living in them, because everybody's moved to the metro areas, we're finding that the people that are still there are mainly older people. They're not young families having children enough to support an OBGYN or to support a nurse midwife or a nurse practitioner. It's one of the problems we're having. It's not the same as in the state. It's happening all across the country in states that did a lot of agriculture. Kids are not staying down home on the farms. They're moving to the areas, and we're getting counties with 2,000 people, 3,500 people, 4,000 people. That's one of the reasons in the rural hospitals. And you need a hospital to deliver babies and all. But what happens is it takes about 45,000 people to support a hospital. And we have all these counties in South Georgia that even all the counties around them that touch them or are close don't equal up with a population of 45,000. And they can't support a full pay hospital. It's one of our problems. We haven't found the magic bullet yet to solve it.
Sadly, if I may, I live in Carroll County but have roots in Heard County, which doesn't have any maternity care providers. And I know there are like about a half dozen midwives in West Georgia in those counties, Heard and Harrelson, that don't have any providers. And those midwives drive into the city to work because we can't get jobs out there. And part of that is because it's part of it is the system and the
number of people at one person.
It's trying to, I can't go work there because I don't have a physician to back me up.
Yeah.
Don't want to deliver babies there, but I'd love to provide prenatal care there.
We did a practice survey this year, and there were several people who weren't working as clinically because there wasn't anyone to work with in that area. So I totally agree. If there's a way to train people who are already there, that would help the pipeline. Also to keep people who are currently there and to make sure that they precept. Because we have 2 students right now who graduated last year and the year before who are not from Georgia at all, but they precepted with a really great midwife and a really great preceptor who's in Thomasville.
A really great
and
OBGYN.
They stayed, and they stayed there.
Right.
So,
there you go, Taylor.
Now there are more midwives in Thomasville. So keeping the pipeline alive is what pipelines there are is going to be very important, I think. In terms of freedom of midwives to practice, Georgia is one of 12 states with the tightest restrictions. The March of Dimes in August of this year wrote in their position statement that in states where midwifery care is better integrated is a lot of different things. Largely what I'm trying to talk about today is just allowing midwives a little bit more say over low risk care, over what kind of care we can provide in the hospitals and the birth centers where we work.
I think we had a committee on this, and this was not my understanding of what y'all would be talking about. I thought you were going to be talking about where you practice and what you did and working with, and I don't mean to correct you, but there was another committee that covered changing the dupes and stuff, and I'll be glad to talk to you, but I really thought you were going to bring what you were doing and on social determinants of care. And I know we have other people that are talking afterwards, and I had sort of said, that's what I restrict it to. Tell me how you make a difference in dealing with people on the social determinants of care. And that's not, and I just think
Sorry,
that
my
maybe you didn't
understanding-
get the correct information from the lobbyist.
Yeah, I think we were under the that we want to talk about what nurse midwifery was, how we were trained, and kind of how we can improve outcomes in the States. But
particularly maternal mortality, but we can skip ahead. I think my point in talking about this was that better integration leads to lower C-section rates, which leads to lower maternal mortality. That's really all I wanted to say about this slide.
Okay. I don't mean to be difficult, but I just gave the other people that are talking instructions that this was about how we deal with it and their experiences and that kind of thing, and asked them to do it. So that's why
No
I
problem.
just
We
want to
can-
be clear about it. I'm not
no,
picking on
we
y'all
want to give you the
particularly.
information you need. So I mean,
So-
we can talk about that for sure.
Yeah.
They only have a couple more slides.
Okay.
Might help us along.
Did they let them go finish it? Thank you, Carolyn. I'll be glad to let us do that.
Why don't we skip to the next one, and we'll just skip to kind of our ideas about, our thoughts about how we can help better with maternal mortality.
Okay, so as far as we're starting to start. Okay,
Yeah.
so as far as legislative actions that we like support from you, or to better support nurse midwives, so we can better support families, we are very appreciative for the preceptor tax incentive program. We have seen a great response from midwives willing to precept, and that's a big part of our challenge. You can't train up a workforce if you don't have people willing to train. And so that P-TIP has really been really good for us, so thank you for that. We also want to make a more diverse workforce. So in Georgia, when she did this most recent survey, only 12.5% were midwives of color. And if you look at that graph, when you look at certified nurse midwives, the composition are primarily Caucasian. We have very little diversity. And so we need to increase the ability of people of color to be able to get into midwifery programs, to be able to become practitioners, to go out and practice and bring that cultural context that I feel that is missing. There's an aspect of taking care of people, you have to really understand where they come from. So I think if there were scholarships or monies available for educational programs that people can apply for to help them be able to go to school, that would be a good thing to come up with.
Do you think the barrier is the cost of Emory, perhaps, or the cost of Emory is one of the
I
major?
definitely think that is a barrier here in the state of Georgia.
Since it's our only school of midwifery in the state?
It's our only school of midwifery in the state, and we also have other schools that are nationwide can come into Georgia and use sites. So even if we had more students, we would not be able to place them because we are constantly competing for sites. So there are distance programs where people can live in this state or where else, and they can come in and train, but they can be affiliated with programs outside of Georgia.
Really?
Yeah.
What, are you, okay, so they're,
And that's because Emory's private?
Emory's a private, like we're like right here as an institution, but they're what are called distance programs where you can, enroll in a university. And if you're in Georgia, for instance, Frontier is one of our flagship midwifery programs. It's in Hyden, Kentucky. So students can enroll there, but they can live anywhere in the U.S. So if you have someone here in Georgia that goes to Frontier, they can find a preceptor here in Georgia to train them and get their didactic training from Frontier. So if they're
Sometimes those are registered nurses working on labor and delivery units or in the hospital, and they even know the people, the people that they work with at the hospital become their preceptors while they're in
right,
school.
but
Okay.
people still can get their training here and not necessarily be affiliated with a Georgia program.
okay, so that means, that's online schools and all, it's like, so our Board of Nursing would have to, they have to be registered, they would have to be certified by our Board of Nursing is letting them do that. And what you're saying is they're taking, I think we had this problem in other places, even if Emory could take more, they have the slots of hospitals and clinics and people willing to take them.
Preceptors are the limiting factor in how big any program can be, because if there's no, half of the training is in the classroom, but half of the training is clinical training. We have students at Emory who go outside of the city and sometimes outside of the state to train where they might be working afterwards, or where they're from, where their families live, for example.
Depending on the state law, if you can
Depending
do
on the
that.
state law. Most states have some reciprocity, not all, between boards of nursing.
Okay, well, if you can come up with, you can talk to the people that represent you and see if there's any changes. I know that we have a problem with that with our schools of nursing. I didn't realize it went on up to the your level, because with the schools of nursing, when we need so many nurses in the state. We're trying to expand the number of nurses we have, and what we hear is the nursing schools can't get bigger because they don't have enough, can't get enough clinical experience because these online schools are taking the slots and they're out of state and they're not Georgia students and all. Okay.
It's the same with advanced practice nursing. It's always
And
about preceptors.
it's all across the board. Okay. Yeah. That's our Board of Nursing, allowing it to happen by certifying the schools. Okay. I'm sorry, go ahead. Yeah.
So there are additional ways that Georgia can help facilitate midwifery practice and distribution. One is to employ midwives in rural areas. We've heard some discussion about placing midwives at the health departments as part of a hub and spoke model. That's a great idea, especially if there was centering pregnancy supported at those sites. That would go even further to improve outcomes for those residents. The patients cared for at those sites could be cared for, have some continuity of care if there were midwives also working as laborists in the regional health department, health centers, at the regional hospitals.
If they did what?
If there were midwives working at the regional hospitals where those patients might deliver, if they're not delivering in a community hospital. So wherever, midwives could be in any hospital, but especially available for, I'm assuming that some patients who live too far out, a lot of them end up coming to be induced in a center that's not near their homes. So it may be different people working in different places. The same midwife who might be working at the health department may not travel far enough to also work at the hospital, in other words. Does that make sense?
Okay, so what you're saying is that do a lot of our hospitals not employ nurse midwives across the state?
They mostly do employ midwives. Yeah, it's that part is not the problem. It's who would be taking care of these patients who are getting their care far away from the hospital. So if they've already got hospitalist care, then that's fine. As far as increasing incentives to work in the rural areas, ideas like further loan repayment opportunities and covering malpractice would really help midwives work in rural areas. The 1 to 4 practice restriction, which you said was under discussion. As far as supporting out of hospital birth for low risk women, this is birth center care costs an additional 20% less, and the outcomes are fantastic as long as the right people are delivering there, as long as there are low-risk women getting the care at the birth center. They're less likely to deliver preterm, and they're less likely to have a C-section. They're less likely to have all kinds of interventions. A way to increase the availability of birth centers, having only 2 in such a large metropolitan area, is it could be improved upon. It would be helpful to remove the certificate of need requirements for birth centers.
Yeah, right.
When Anjali Hinman was setting up the Atlanta Birth Center, she
Want to
said
see my scars from trying to open up certificate of need? Yeah.
Oh, okay.
So,
Got it.
I mean,
Yeah.
good luck.
But it's an additional, it took her a year and $30,000 worth of
I know,
consultants to get that.
it doesn't
Okay.
work.
Okay, next. Funding for Reducing Primary C-Sections program. This is a program run through the American College of Nurse Midwives. It costs $7,500 annually for a hospital to participate, which is less than the cost of 2 C-sections paid for by Medicaid. Hospitals that are taking part in this nationally have reduced their C-section rates by a median of 8% and by as much as 18%. So it has made a very big dent in the C-section rate. Let's see.
And who's that program for?
Who
participates
it's for
in that?
hospitals. Hospitals.
Hospitals.
Hospitals have the program, and then what it involves is a quality improvement program that the ACNM supports.
And it kind of focuses on normal physiologic birth, so it kind of talks you through,
It standardizes care, sometimes by kind of regulating the amount of time that's allowed for labor and increasing it, sometimes by adding more support. There are a few different options of ways that the hospital could choose to try to lower their C-section rate depending on what works for them. One of the options is intermittent monitoring. Hate to say it.
Okay, this is done for staff or for nurse midwives.
It's done for hospitals. It's a hospital-based program, so
But
it's not just for,
who-
but the midwifery organization is the one who offers the program.
Yeah, but who's taking the course? Staff, just the general staff in the hospital.
The
Okay.
physicians, the midwives, and the
Everybody.
nurses.
Everybody.
Everybody.
That's what I'm trying to
Everybody
get
on
at,
the
is who's
unit.
taking it.
Across the.
Okay, got it.
The department.
Got it.
Okay, you can go on to the next one. And then the next slide, please. And then, oh, maybe I missed it. Birth center accuracy, birth certificate accuracy. Right now, we really don't have a good idea of what our outcomes are for midwives, and we imagine that you would want to know exactly what they were. We know what our practice outcomes are, but as a whole for the state, we don't know them because birth certificate provider data is not done correctly. For instance, at Northside Hospital, all of the births are coded to physician delivery, even though midwives probably do about half of the births there.
Okay.
So we don't know how to evaluate ourselves.
Okay. Okay. All right, you want to ask Neil? Okay, Representative Stovall. Huh?
We're
Can you
good.
wait? You gotta quit. You can
Thank
wait?
you.
Okay, go ahead, because we need to finish up on time.
I'm
No, go
happy
ahead.
to take questions.
Oh, okay.
Okay. Thank you, Madam Chair, and thank you for the presentation. I had two questions. For those who are already practicing midwifery, is there a consideration given for years of experience if they go into the training to get the certification?
No.
Okay, so they would have had to start with I guess with the schooling or the training.
So they'll have to they become a nurse, so they go through like a nursing program, but there's no requirement that you have to practice a certain amount of years before you get the midwifery training. So a person can graduate nursing school and come straight in to the midwifery program, but that's kind of like school, schools can determine if they want to require practice experience if
And
they want.
Representative Stovall, many of the schools of nursing now practically give no OB. Like when I was in nursing school, it was 3 months. But now we have schools who, I know of one school that doesn't require any OB, all right? And some schools basically walk through for 2 days or something and observe, and that's all they get in their basic training.
So what we try to do with ours, like if we know that they're gonna come into the midwifery program, we try to get them to do their role transition. So at the end of the nursing program, they have to do an extended, 180 hours in a concentrated clinical area. And then when they come into the midwifery program, we do like an extended role transition where we try to get them to spend more time. And then we try to put them, so like some of us are practicing as faculty, if we know they don't have as much, we try to put them with us in a clinical setting
Right.
to try to.
But that's Emory. And Emory added those a few years ago when they realized the nurses were coming out with a BN, didn't have enough clinical experience. They were getting the book knowledge, but what happened when we went to academic, when we went from diploma schools and we went to academia, something had to give. In the 2-year schools, you had to have your basic college courses, so clinical gave. In the baccalaureate schools, you had to meet your course requirements, and so clinical experience went down. Emory's one of the first that added this extra special
Right. And
training.
I've tried to recruit. I was a labor nurse, and most labor nurses like, I don't want to become a nurse midwife because they know the hours and different things are challenging. So sometimes it's even hard to get the experienced nurses to come back and go forward.
Okay. My next question is, what is the average cost for a certified nurse midwife from the time that you all might start in the first trimester to after pregnancy? Because I know you had a cost factor that you were doing the comparison was, and I didn't know I saw $2,260 per birth. Was that the cost for C&M, or what was that? I guess because we were doing a comparison. I know you did an overall on the cost for a cesarean, a C-section, and how that could save the state some money. But I guess looking at individually, the cost for having a midwife, what's the average cost per patient, I guess?
So the cost, midwifery care is reimbursed at the same rate as physician care. But what happens along the way to our patients is different, and that's why the cost is different. So like when I say that someone cared for by a midwife, their care costs $2,000 less, most of that is because of the reduction in preterm birth and a reduction in episiotomy. C-sections obviously cost less also.
Sure, go ahead.
All right, I'm gonna go back to my first question I had asked about. Thank you for the clarity on that. So I know I had talked with some current midwives that have been practicing for years and might not have gone through the program now that's in place. And I just was trying to figure out how are they integrated into this, or are they not integrated in, or I guess I don't know if it's a confusing question.
How they integrate into?
You don't take them like being an LPN and working them in with the hours they're saying.
No, it's all like you have to be an RN with a BSN, and then you have to attend a master's program to become a midwife. And then whether there's RN work experience kind of varies between programs. I don't know if that's what you're asking.
Yeah, that was kind of, because I was just trying to figure out the ones who've been practicing, for years,
Mm-hmm.
and then now we have this midwife program training, and so now are they going to have to be required to go get certification? And if so, with those years of experience that they've had and looking at their rate of positive births and all that, is that taken into consideration? I guess
Are
that's
you
the
Are you
question.
asking about CPMs, certified professional midwives?
Are you talking about are you not talking about nurses? You just talk about somebody who's been out there delivering babies?
Right.
In general, is that taken into consideration? I mean, I believe that that's important. I mean, we have all these certifications and various things, but I think that, there should be pathways created that people can obtain that. And I think that as a midwife, I would like to know if you have some birth experience, if you were coming into an academic program. I think that's a positive thing. So
But what she's asking is, do you give a year's experience off the 3 years it takes you to go? And the answer is no.
Oh, mm-mm.
Yeah, that's the question I
No.
was
That's the
asking.
question.
Okay.
Like that. So I've been doing this for a while. I have these questions. So, okay, who? Somebody else have one? No, that's it. No, okay. Go ahead. Are you finished or?
Yeah.
We're finished.
No, thank
Okay.
you so much.
Thank you very much. Thank you for your job to do. I would say that I think probably the value, which is you can't measure money-wise, is on the hours you spend and the care you get is what makes, but that's nurses for you.
Yeah, the
As a nurse,
holistic-
I can say that. We listen, we like to talk to people, we like to educate about many, many things, and I think that is something that is really immeasurable and help us with positive outcomes on the nurse midwifery program. Thank you for what you do. Thank you for teaching, and appreciate you taking your time to come.
All right, thank you so
And I
much.
hope I didn't give you too hard a time for. I just
No.
was trying to make sure that other people didn't think I had told them differently than what I
Madam
put
Chair, we
out.
don't mind. We have PhDs, so you train, and this is good.
This is good.
This is
Okay,
good.
there we go.
All right,
Well,
thank
you're
you.
welcome back anytime.
right, thank you.
Okay, thank you. All right. Okay, I'm going to Zamar. Is it Saimah? Okay. How do you pronounce it? Zyma. Sorry, I'm sorry.
Where would you like?
You want to stand or you want to sit? It's up to you, ma'am. I'm not going to get it.
I'll sit if it's okay with
You sure, it's fine.
you. Thank you very much for this opportunity. I've been following.
You can move it. There we go.
Thank you very much for the opportunity. I've been following these committee meetings, and I'm very much interested in the outcomes here.
Okay.
And I'm also nervous.
No, don't be nervous. I
So
may
my-
talk a lot, but I don't bite. Not to people who are nice enough to come testify.
My name is Salama Abdullah Zaima. I am a midwife. I have been doing births for almost 42 years. My first babies were born January 19th and February 8th of 1978. I've delivered over 4,000 babies in 10 states and 4 foreign countries. I was the first African American graduate of Emory's Nurse Midwifery Master's Program in December of 1991, though I walked with the class of 92 in May.
Congratulations.
Thank you. The U.S. has the most educated, most technological, most expensive healthcare system in the world, and the worst outcomes of any industrialized nation. Our maternal mortality rate has gone up for the last 30 years, while all other industrialized nations have gone down. The other industrialized nations use midwives, and most of them are not nurses. Now, I'm not a doctor basher. I'm so grateful that we have doctors and hospitals for problems and emergencies. But OBs never see a normal labor and birth. They come when a nurse sees ears. They catch the baby, they hand it off to another nurse, and go sign the paperwork. Midwives are experts in the wide variations of normal labor and physiological birth. Like any bell curve, most lie in the middle, but there are outliers still within normal. OBs study pathology and everything that can possibly go wrong over even the most rare. If a situation is questionable, you tend to see what you're looking for. The benefits of peace and quiet, undisturbed, loving attention are often not recognized or respected in a hospital setting. If fear or anxiety trigger the fight or flight mechanism, releasing adrenaline and cortisol, it signals the body that it is not in a safe place for a vulnerable new life to emerge. Adrenaline then slows down or even stops the labor to allow her to get somewhere she feels safe. It's called failure to progress, the most common cause of a C-section. A woman is at least 5 times more likely to die after a C-section, which is major surgery, than after a normal birth. 32% C-section rate in Georgia. 1 in 3 women can't have a baby. $30,000 to $40,000 for a baby. Something is wrong with this picture. We keep doing more of the same things, throwing more money in the same directions is not working. Instead of sending grass-green graduates to gain experience and pay off their school loans on the bodies of the poor and marginalized, only to see them leave once they have learned something and go where the money is. The answers are in the community. We must look within the community to women who are already respected, already trusted, already asked for their advice. Women who are not leaving in a couple of years, who know the culture, the family histories, and already care, the part you can't teach. These community-selected women learn the essential skills through didactics and apprenticeship to follow a woman closely during the prenatal period, preventably observing for any minor deviations towards abnormal, and working on them before they cross the line that makes them a problem. It's always easier to fix something minor than to wait until it's a full-blown problem. Community midwives are skilled in recognizing potential problems, medical danger signs, when to consult, refer, get a mother to the hospital as needed, and/or handle emergencies on the spot. According to the Moultrie Observer, 93 counties in Georgia have no doctor, no hospital doing deliveries. Is it not safer to have a skilled expert in normal birth at your side in your home as opposed to in a car by the side of the road? 2/3 of rural births occur outside the mother's home county. The emergency drugs we are requesting can be safely administered with training by a layperson. Example, vitamin B12 for pernicious anemia is self-injected or injected by a family member. Also, 2 weeks ago, I was at the Black Infant Summit at Morehouse, and there was a 9-year-old boy who self-injected insulin under the watchful eye of his care provider in the child care room. None of these emergency drugs has any street value or use as a street drug. Direct entry midwives already carry and use these drugs in many other states. Telemedicine can connect a rural doctor with a distant specialist to discuss a client's case, but you still need a knowledgeable person with the client who can make a report to the distant doctor of the client's signs and symptoms, history, complaints, vital signs. You still need boots on the ground, knowledgeable enough to convey to the distant expert the information needed to make an intelligent plan of care. I also wanted to talk about, I also lived in Brownwood, Georgia, in Terrell County, and worked in the local hospital. This has been many years ago. Very small hospital. You had one RN, one LPN, and an aide to run the whole hospital. We were the labor, delivery, postpartum, sick people, babies, and I'm pretty sure that they're probably not doing births anymore. But in rural areas, some of the reasons why women don't get into care is transportation. Now, there is transportation provided, but I know a young mother. She has 3 children under 5. And the van, the Medicaid van, will only pick up 3 people. So she can't bring all of her children. She's a transplant from Ohio. She doesn't have any family here. And she has nobody to leave her children with, and she's high risk, but she hasn't been to the hospital in 2 months. I am part of Bellies to Babies Foundation, which is a nonprofit here in the state, and we have a emergency number that women or providers can call if they have someone, if there's a problem. And so these are some of the problems that we get. We had one woman who called us feeling sick after postpartum, and that's where we're losing a lot of mothers. So we advised her to go to the hospital. She went to the hospital. They sent her home. She called us again. We advised her to go back, and they sent her home the second time. Now, her problem was that nobody looked at what her normal blood pressures were, because her numbers were running around the 120s over 80s or 90s. It wasn't considered a problem because 140 over 90 is a problem. But her normal blood pressures were 90 over 60 or something like that. So if they had looked back at what her previous situation was, maybe they would have kept her. But the third time we heard from her, she was on her way to the hospital in an ambulance after having had seizures at home. A lot is just not paying attention to what the woman is saying, or not considering that she may know what's going on with her body. I wholeheartedly believe that the answers are in the community, and that we need to retrain women who already are there, who are already living there, and that who already care about the people that live around them. And I think that we need to look back. I think that will be a very inexpensive way to increase the care that is given in this state. And even in a city, if you have somebody in the projects, or somebody in the church, or somebody in the community center that can help with doing prenatal care and making sure that the ones that need to go see a doctor go, I just think that that's really important.
Okay, thank you. Questions? Question from anybody? Thank you, and thank you for your service for
Thank you so
many
much
years.
for
And
hearing me.
I think you've heard that we've talked about the community, people in the community, and I think that there's a key there, maybe with peer support. I mean, OB, student nurses do mother-baby courses. It doesn't take a master's degree in nursing or a regular degree in nursing, to do the basics, not all the in-depth, but certainly to do basics. And you were here last week.
Yes,
I think you
I've
remember
been
the
here
one,
all but one meeting.
the one county where they're using nurses, just RNs to go out, where Warner Robins is.
But it doesn't require a nursing degree. It
Right.
requires somebody who's there and who cares and who look in on a lady and figure
Peer
out
support.
why she hasn't seen her lately, or. Thank you.
You're welcome. Oh, you have a question? Go ahead.
Yes,
Representative Stovall.
And you actually just triggered this question. I was thinking back, maybe in the early 90s, I worked with a program called ZAP Asthma, and they had community health workers that worked in the community. And I was just thinking, when you just talked about not having a nursing degree, none of us, had a degree. We were trained to look at the symptoms about asthma, and we were sent out into the community in those areas where there was a high risk of asthmatic patients, and really encouraging the parents to make sure they're doing the medication, following the management plan, and all of that. So I was just wondering, what are your thoughts on something similar to that, community health workers in those areas where we are seeing or know that there's a high risk factor, or even before it even gets to that point?
Yes, community health workers are doing excellent jobs all around this country. I just feel a way because I feel like the medical establishment has hijacked the name midwife, and that this is a job that women in the community did since the beginning of time, and now all of a sudden it takes $60,000, $70,000 education to be called a midwife. And just like there are different levels of nursing, then you have your practical nurse, you have registered nurse, and you have your master's level and your doctorate. I mean, you can have different levels of midwife. And I think that the ones on the ground, the boots on the ground in the local neighborhoods, I just feel like they should all be given the respect of that name midwife also.
Well, I certainly think community workers, I'm sorry I don't have the chart with me. I had it with me a couple of times. In the early 1900s, the death rate of mothers was tremendous, up around 900 a year, something like that, if I remember the chart correctly. It had gone down, and a lot of that was home deliveries, and and deliveries from people that weren't trained to deliver. And part of it was the times also, but it had gone down. It is going back up again, but it had gone down almost, very, very low. But we are seeing a tick up. So I just think we have to be careful.
That was also a time when black women weren't permitted in the hospital. They weren't given the choice. I'm not saying everybody should be able to have a baby at home. I'm not saying that. I'm saying people, we've learned a lot over the last century and a half or whatever. And people low risk, basically healthy people are going to choose to have their babies at home. And I don't think anything is going to stop that. And I think that we really have a responsibility to make sure that the people that are out there do have the basic knowledge and skills that they need, that it's safe.
Well, it's just like, but when you say there are different levels of nursing, you know, a nursing assistant doesn't do what an LPN does. And so I think there definitely is a place, and this is my own personal, for women in the community and community health workers and women who know it. But as we get up on the scale of delivering babies, and that becomes another discussion, but it's one, you know, that occurs, and differences of opinions. So
Yes, most definitely.
You like
And
that.
babies, you know, most babies are coming out anyway. If they're in the closet, if they're in Macy's window, if they're on the bus, you know, police
they're
officers
gonna, when they're
deliver
ready,
babies.
they're going to come.
I was a New York City police officer, actually, when I started catching babies. And the training that I got in the police academy was hands off and it'll be okay.
Okay. I wonder if that's what they still give them. Thank you very much for coming. Ms. Simpson. Hello.
I'm actually Danielle Rodriguez from
Okay.
Sister Song. Ms. Simpson actually got sick.
Oh,
So
sorry.
I'll be here to speak on Sister Song's behalf, Black Mothers' behalf, and just go from there, okay?
Okay.
I did take my notes because she just told me, just so you know, but I've been following along with you all. And I'm really thankful that you all are here to actually listen to what the solutions that we think that you should consider, because we do know that the numbers for our actual Black mothers are the highest. And we would like to have the conversation where you bring us into that conversation. It's a lot more, excuse me, I'm shaking a little bit, but it's only 2 people up here that look like me. And I'm thankful to see them, but it doesn't make me feel safe with how serious this issue is.
Are you talking about us, 2 people up here?
Yes, I'm talking about
Okay.
the 2 women that look like me on the panel. But I do know that it seems like the trend here is all about solutions today. So I did want to talk about the conversations about high and low risk pregnancies and the suggestion on needing to update that. Right now, you're considered high risk at the age of 35. I'm 38. I'm thriving. So I would like to see if there's any way that we all can start having that conversation, because when you call us high risk, we go into our first prenatal appointment and we're scheduled for a C-section. That's pretty much what happens. And if we don't have the knowledge to question that, then we just go, oh, well, you say I'm high risk, so I guess I'm just gonna have to have this C-section. But what happens is that we're having these C-sections and then we're dying. It's causing problems in our community. So I don't know what that process is, because I am not a nurse, but I would like for us to start having a conversation about high and low risk and really, really digging deeper into that, because it can't just be about age alone.
Dr. Ellis, who does that? Is it the National OBGYN?
Is at risk for having a baby with a chromosome abnormality. It doesn't necessarily mean that she is unhealthy or is risk for other things. So I think we just have to be careful when we start talking about what risk and so forth.
And do they-
So yes, 35 years of age is considered high risk for having a baby with a chromosome abnormality.
Okay,
and
but
that's
do they,
across the board.
I mean, is it automatically, is the recommended treatment automatically at 35, a C-section?
Absolutely not. I'm not.
Right. So that's something else that I think
Okay.
that we should start having another conversation about. It's because there's such a rapid movement when we do go to our prenatal appointment that not only are we scheduled for C-sections, we're rushed. We're in and out. So it's not really, a lot of times, like I came to the last session and it felt like it was our fault that we were dying. And I don't think that was the intention, but that definitely is how it felt, because it's not about us eating McDonald's. It's not about us going to the gas station to get us some fruit or anything like that. It is, we're going to see a doctor, a provider, to actually take care of us. And the first thing they do is, you're 35, I'm going to schedule you for a C-section. The second thing is, I'm just going to rush you into this process. So there's no education involved in our decision making.
Right, but I don't think that you can say, I mean, the rates are going up, but we are becoming an obese nation, and the rates are going up on death for cardiovascular disease across the community. I mean, across everybody, we're having more diabetes. I've got a sister that's having 2 toes removed this coming week because of not taking care of herself. You know, and we are a nation that's getting sicker overall because of what we eat, our diabetes, the fact that we don't exercise, and that does affect pregnancy. So I'm sorry if you felt that way last time. It was not. It's just that I think we have to realize that there are things that do cause medical problems. Mm-hmm. And women and pregnant women are not exempt from having those problems. If you come in pregnant with your blood pressure already sky high, and it was sky high before, then that does perhaps lead to a problem with it, mm-hmm. and to preeclampsia. So I'm sorry if it came across that way, because I know that's not what the presenters wanted. They're trying to see where we need to help people. Mm-hmm. I mean, and it's like talking about peer people. If we know that people in a certain segment, if African American women are running higher blood pressures, then maybe with the community support, we need to work on lowering those blood pressures, you know, before they're pregnant, mm-hmm. to try to help. I mean, right. But I don't think it's just.
I don't mean to cut you off.
No, it's all right.
But
go ahead.
As far as Black women, Latina women, we are the most marginalized. Our stress levels are extremely high. Yeah. But we have seen successful births with high blood pressure. We have also seen successful births when you're considered obese, but not really. So I just feel like that's not the direction that the conversation should be in. The conversation should be in centering Black women, centering Latina women, and having the conversation on what exactly it is that they need to survive, because if you save them, you all will be saved too. I think that we should all, I don't know if Angela is here from Black Mamas Matter Alliance, but they have done a review and they have suggestions listed in their pamphlet for you all to look at if you're interested.
Can you get it to me?
I can definitely do that. Also, we Sister Song and the Human Rights Initiative did an actual report as well. It has a great deal of information, but as far as Sister Song and myself, we back Black Mamas Matter Alliance and the suggestions that they have made in that report.
Can you get that to my office right away?
I can, definitely.
Sure.
I just want to make sure there wasn't one more thing.
Do you want to answer questions now? You want to ask now?
I want to insert something.
Yeah.
I just want to see if the presenter was talking about the lack of cultural competency among medical professionals. Is that where you're going with this conversation?
That is definitely where I'm going.
Okay, because we did talk about that at our very first meeting, mm-hmm. With the medical schools, and we talked to them about what they were doing to train upcoming physicians in cultural competency, because that is part of the problem, right, that Black women are not heard when they present with certain complications at the same level and at the same intensity as others. So that's what we're talking about now. That's what you're talking about.
Yes, definitely.
Okay.
Okay. Thank you, Carolyn. That made it clearer. Thank you. You're right. Deborah.
Thank you, Madam Chair. And I want to thank you for coming and say, first of all, that I agree with Representative Hughley that we did speak to that in the first meeting as far as cultural competency. But second, that we're all women up here. We're all women. And I know in both my pregnancies, because I'm a double cancer survivor, that I felt scared, I felt threatened, I felt rushed by the doctors. I felt a lot of the things that you mentioned. And so I think part of this is being a woman and understanding that it's kind of a universal thing when you're pregnant, that you feel vulnerable, that you feel like you, because you're carrying another being, right? That you feel responsible for that other being, and that you feel vulnerable and scared because you don't know what might happen to your body or to the baby. And so, so I think that's a part of this too, is recognizing that we're all women.
Definitely.
And
Yeah.
everybody who's had a baby can empathize with your feelings.
Yeah, no, I definitely agree with that. I just think that with the numbers, it's showing us as the highest number there. So
Right.
I understand that your story actually sounds like mine. You know,
Right.
I was scared. I was very afraid. But we need more support when we say that something's wrong. So I do appreciate you bringing that up as well. I did want to mention about Medicaid extension, not necessarily expansion, but all we're asking for is 2 extra months, because we are losing a lot of them to postpartum depression, postpartum problems.
And Chairman Cooper has asked for that.
I am battering them. You may not have heard me say it over and over again.
Yeah.
I'm in the governor's staff's office. I'm with over the asking DCH commissioner. Every time I'm chance, please, can you look at this? I have things, I take them. So we are trying to get that extension.
Well, let us know if you need our support to back
Okay.
you. We'll show up in numbers.
And I feel like I'm making some progress.
Yeah.
It's just that I'm probably one of the most vocal ones down there from legislative. I get pretty vocal, as you can tell from this. But you got other people pulling for 50,000 other things for children and for people that have brain injuries and
Right.
everything else. But I'm in there. So please know that it is a priority for me, because I truly believe that will help us prevent, the deaths from suicide, deaths from cardiovascular disease, that women need to be helped. And one of the things about it, they'll take the babies often to the pediatricians, and we can't make the pediatricians, they'll tell you they're not qualified to take care of other problems, but I think transportation for many people is a really important issue of being able to get back, even if we expand it, to get back for those visits again, and community people working with them to understand how important it is to go back, and trying to facilitate that is one of the big issues, because I think it's one of the reasons that mothers skip even the first one, because there's a high percentage that skip.
Yeah, and I think that
Them first back.
I think we need to put more confidence in Black women and trust us more, because we can advocate for ourselves if we had the resources and the knowledge. So lastly, I wanted to talk about was just our to encourage you all to have a conversation, but also to consider the different pathways to delivery, especially because we just had Mama Salama up here, and you heard her number of births, and it's an honor to be in her space. Every time I see her, I'm thankful, because I know that her numbers didn't add on to the numbers that you all are talking about. So it would be really good for us to back community midwives, community doulas, just as much as we back the certified nurse midwives and the certified professional midwives.
You do know that there is a case where there was a really bad outcome that's causing a lot of angst across the state. And, it's
That was
bad outcomes
that was
too.
definitely that was a certified professional midwife.
Right, but but they supposedly have the experience too, and it's just caused a lot of angst in the.
I understand.
Now the board committee, where bills like this have to go,
Yeah.
and that's why I said we need to consider those in other areas. That bill went to the GORC committee, and they voted it down and said that they did not feel like they should be certified at this time or move forward on that bill. And I'm just telling you what came up in a lot of in the discussions, I think, from the people pro and con, is that what had happened in that case, and also in putting forth some of what and I know that may not be the same, but in making the decision of what's high risk and not what's high risk. I mean, for example, they talked about doing home births on repeat when people have had C-sections. And that is one of the times when there's most likely to be a problem as far as the medical community and even a group that normally supports them says absolutely not, that you don't do home births on people who've had C-sections because of the chance of the uterus rupturing. And when that happens, you've got about 5 minutes to get a baby. I think it's 5 minutes or something like that to get a baby out. Look at the nurse minutes. I don't remember the exact time, and even less before the mother hemorrhages to death. So it's just a real hard for the state to sanction something, you know, when you're having that kind of questions about it.
Right,
So,
I get it.
I mean, it's just
It
trying
just
to
sounds
look-
like one situation versus this massive situation that we have.
No, I'm
in
just
regards
using
to
that as an
maternal
example. They
mortality.
looked at the whole thing. That wasn't why they made the decisions. Darlene, Representative Taylor, do you have a question?
Hi.
Thank you. I wanted to thank you for sharing with us. And one of the things, I think Deborah talked about it, we are all women. I had difficult pregnancies. I lost my grandmother. I never knew my grandmother. She died in childbirth. And this is something that stays with you forever. And even when I had my children, I had difficulties and had preeclampsia, and I still have anemia today. So this is a concern for all women, and I think everyone up here wants to address that. And whatever means we can do, we're going to fight for it.
Yeah.
I too have been pushing with the governor's office. We all have. We know we need women to have good health care, and they're bringing our next generation. We need to make sure that they're healthy. So I wanted to assure you that we're all after the same goal, and I think we'll get there. Thank you.
So, Carolyn? Representative Hewley.
Madam Chair, I just wanted to know if your organization or the other organizations that you are partnering with had any recommendations regarding how we can get mothers into prenatal care earlier. Did you all address that in any way? Because that's one of the problems that my folk at home tell me, that if we can get expectant mothers into care earlier, and if we can get them expansion on the Medicaid time frame,
Right.
is the two things that I'm being told by my people at home. So I was just wondering if you all had any recommendations on how we might get women to care earlier.
We have definitely talked about this. We understand that the state of Georgia doesn't allow sexual education in the schools, but we do believe that that is very important because that's giving everyone the foundation on what they need to know, you know, in order to procreate when they get older or whenever they choose. So we have had that conversation. We also, at Sister Song, we offer trainings in regards to raising your children, how to advocate for yourself. So I don't necessarily think, I definitely think that if we expand Medicaid, yes, but maybe the issue isn't necessarily that they don't go to their appointments early enough, like unless we're seeing numbers saying that because they didn't go to their appointments early enough, that's why things are happening to them, versus them just feeling like, no, everything's okay, I've done this is my third pregnancy, I don't need to go.
Well, what my OBs are telling me at home is that they are having too many expectant mothers present, and they're halfway through the pregnancy. And the things that they could have done or should have done earlier are not being done, and that contributes to poor outcomes. So that's what I was asking, if there was something in your research or some examples that we could possibly initiate to try and help encourage women to present earlier to whomever their healthcare provider is.
There we go. I'm glad you said that.
It's the doctor or the doula or the visiting nurse, whoever they're using, they need to get with that professional or that healthcare advisor, let's say, earlier, and I was just wondering if you all had any suggestions on how we might encourage that.
I can actually get with Angela with Black Mamas Matter Alliance and send that over to you as well.
If you'll send it.
Yeah.
And I think that one of the things I've talked about is people are coming out of the woodwork to talk to me about things. There was people who run a computer program, and they're working with our disability community and getting jobs. They're using this computer program, and they have on this socioeconomic causes, and they have put in data not just from the state, but they have put it in from all the federal data that you can get on where people live and the socioeconomic and all of those kind of factors, and they can really pinpoint. They were doing it on deaths of infants in that first year. And one of the things that came out was how you work on different areas. And what they found was in this one area, they were using a town in using Ohio, and they can tell when they went for prenatal care and if they went to postpartum visits and if they got mental health care and all the things that go along with this, was spacing the pregnancies. They would 90% if you could get women and get them birth control to space the pregnancy. Dr. Ellis is sitting down here. It would decrease. It made a major decrease in the number of infants you lost if you could span that out by a year in the areas that they were working with. And I'm sitting there and going, okay, so here's data that tells you work on like you say, work on this issue if it's knowledge on birth control and all. So I'm asking if they could go talk to Dr. Toomey and see if they could help us with the data to see if we can get some pinpoints, and it pinpoints it down to like they could give you your community, Carolyn. And it would be like how many prenatal visits they go to, when they start, all that kind of information that leads you to pick out where maybe it's the worst parts in the state. I was really amazed at what we can find out with the kind of data that is available from all over the country in trying to help us get to this. I will tell you that I was glad to hear that in order for birth control pills to be not have to be ordered by physicians, a company has to ask for them to be sold over the counter. That's right. They actually have to ask the FDA. And there are now 2, so the company has to ask. So that makes them. So now there are 2 companies that have asked the FDA to allow their birth control to be sold over the counter.
You don't want to get me started on birth control.
I know.
Like, that's a whole nother journey for
I'd probably
us.
be right there behind you.
Yeah,
on
definitely.
the need for it. But I was heartened to hear, and I said, how long does it take them to get an answer?
Yeah.
And they said, usually about a year. And I'm going, well, gripe it. Couldn't they move a little faster to get us to make birth control more accessible for people who want to be able to get a hold about birth? But there's a whole nother issue about birth control too.
Right. I did want to ask a question. You've been mentioning how each Board of Health is based on the actual counties. It's not necessarily like a Georgia situation. It's county-wise. Mm-hmm. Do you encourage us to actually push into other counties to start having this same conversation?
With whom? I mean, how would it help with your county?
Basically, she's saying because the county boards of health are not centralized,
right?
And each of them do things a little bit differently. Their organization, it would be helpful if their organization would do some outreach to some of the other counties, mm-hmm. particularly on those things that you all have found to be successful.
Right.
Now, some counties are doing centering and group prenatal visits and mm-hmm. that kind of thing, but others are not. Gotcha. And because there is no one size fits all, and there's no one person that says we're going to do this universally in Georgia, that would make sense to reach out.
Carolyn, who do they go to, though? I mean, that's what stifled me for a minute. like in my county, it's Cobb. I don't know who the group would reach out to. Would they reach out to the doctor and had it and ask for a meeting, or, I mean, would you go?
I know one thing, the county pays the rent for them, so somebody
Right.
at the county should be able to tell you
Who to go to?
who to go to, because they
Okay.
have to pay.
Because I can't imagine going to the board.
Sure, I went to the nurse in charge and got it done.
You went to the nurse in charge and got it done? Okay, so I guess it varies.
It
It
depends.
depends on where the county is, but it's certainly worth
I would go to who pays.
who pays them?
Who pays? Who's writing the check to pay for them to be
Well, it'd
there?
be the county.
Thank you so much for your time. I really appreciate it.
So thank you for coming. So, well, we were going to do a little discussion on where we're going, but can we just do that by emails? And if we need to get, okay. Pardon?
I want to speak.
Who are you? Oh, Abel, I know who you are. Come on, you get a couple of minutes. Come on up here. I was teasing you.
I want to say thank you very much for members of the committee. I didn't make all of the meetings, but I made some of them. And what I would like to do is to thank Chairman Cooper for being open enough today to make sure as a part of your gathering of information that you had people specifically from the community. Queen Umsala, is the best. What I mean by that, she came at today credentialed. She came as the first African American woman. I want to do this for the benefit of Ms. Hughley. She was out at the time. She's one. She came as one of the first graduates of the Emory University School in terms of midwifery. 1991. She walked in 92. She's delivered over 4,000 babies and has a breadth of information, and even has a background as a police officer. So her life has been this way, broad.
A lot of life experience.
Yeah, a lot of life experiences. And basically, even though she was credentialed, she still, if you remember her testimony, said that people have been having births from the beginning of time. And in a lot of, even some legislators, I did a little survey when I was doing a lot of work with midwives and asked them, who among you were birthed by a midwife? And they didn't mean no certified midwife, they didn't mean no nurse midwife, they meant midwives. Because up into, I think around the 60s, there was at least some numbers like 5,000, I think, direct entry midwives, lay midwives. And then over regulation, there's been a decrease, but now there's a movement abroad in the state for more midwives and doulas, and it's becoming more popular, and so people are interested in midwives again. But also I want you to say, what Umsala said is that somewhere or another it seems as if they have, I don't know if she said kidnap, but the word spirit, hijack, that's it. You know it was a word like that, hijack. So what it is now when people think about midwives, they almost not even talking about midwives in terms of lay midwives or direct entry midwives. They basically talking about either certified or nurses, as if that's how it started.
Nurse midwives.
It started the other way, so don't get it mixed up. It started the other way. And so even though she's credentialed as she is, what she said to y'all and us is that still she supports direct entry community midwives, because she knows that the problem that we have in Georgia is not normal. Even though we can be happy and say, well, other states mess up as bad as us. Now, we're never in a race in Georgia to try to be with the people who bad.
Yeah.
We're not in that race.
You got that right.
We're not in that race. We're in a race to be at a higher level of things. And subsequently, it seems to me that when you are in extraordinary circumstances, you must do extraordinary things. Some of the things, I had an appointment, I'm late for it, it's okay, because I think this is important. I wanted to be sure that y'all understand the expediency and the need for something to happen. And even though it is a big job, I submit to you that some of the recommendations could be something around, obviously, more money in the budget. The health workers, some of the healthcare workers to be trained already just there, or just people who are there who could be support to help people get to prenatal and that type of thing. The two groups one group that spoke to you was Sister Song, all right? And they're based right in Atlanta, right in the West End in my district. And then you have the Black Mamas Matters Alliance, and they will want, Angela could not come, but I talked to her this morning. So I'm saying that there are still, I know all your organized time may be over, but there are some specific women that I brought to organize to the first meeting. We had 46 black women in this room, and they sort of got disillusioned because they thought it was so much around data and death, that they didn't come back, but at least 10 or 12 of them have come back every meeting. So I don't know if there's any opportunity, and we will make sure that information gets to you from Black Mamas Alliance. But to me,
Look at me, if it gets
Okay.
to me. I mean, I
Yeah,
can give it
yeah,
to Carolyn too, but make sure I get it, maybe.
yeah. So in other words, y'all, what I'm saying is that we have an opportunity to do something big, and we can play small because Georgia is sort of, moderation and wisdom. I understand that, but sometimes because of where we at, we got to play full out. Just like members of your committee said, they had issues at birth. So when are we going to speak up for women? If you don't speak up for women, you don't speak up for families. And so what I'm asking y'all to do as a committee is to go out on the limb. Go out on the limb right now. And what it is so we can put this as a major issue on the agenda, because we decided. Now, who I am in the matter is I'm the author of the first mandated benefit in the state of Georgia that requires insurance companies to pay for mammograms, pap smear, and the prostate cancer test. Every woman in the Georgia General Assembly at that time, both black, white, Democrat, and Republican, signed off on that bill. And so since that time, it hadn't really been a lot of bills that black women, white women, and Republicans and Democrats have signed off on. But the reality of it is, this is big enough. This is big enough that we can show again the type of power that we have as women and put this on the front burner. Ask for more money in the budget. Keep pushing the governor. Renita Shannon has a bill that talks about Medicaid expansion. I think it might be longer than 2 months, but we'll take what we can get. But the point of the story is, where we at in Georgia is an opportunity to go play full out, take risks, be not disliked, whatever it is you have to do to be, but to come back with some strong recommendations that move the needle forward in Georgia rather than incremental changes. Because even the review committee data is 4 years old. I mean, they talk about 15 being available January. So all it is that if we don't do something extra in this committee process here, then what we do is we keep on gradually, and people dying, black women dying, white women dying, but obviously we are dying disproportionately. And I can't not, as a black woman, just sit around and act like it's not something of critical epidemic. I mean, people talk to me about this all the time, and I was asked to be a speaker at Sister Song's conference, and I was able to ask to be a speaker. And I talked about reproductive justice issues and that type of thing, but I also had to talk about maternal mortality because it's on everybody's mind. And I just gonna leave it right there. But y'all, I really want to say, I don't know if you can feel me, but I know this is an issue that people can agree. If we as women agree that it is an issue that should be put on this agenda and play full out on it, I think we can make some progress. Thank you, Madam Chairman.
You're most than welcome, and I know you've done a lot of them work on this issue in the past, Mabel. So I thank you for your representation, and thank you. Okay, could I get the committee members to send me specific, or send Tara, and then she'll let me look at them. Don't to Tara. How soon do you want? Not yesterday. End of week, is that too? Monday? Monday, give them the weekend.
I tried. Okay.
I got the governor, I got the speaker to give us an extension, so I like that. Okay, we've got a question. Wait, ladies. Down. Okay.
So after we submit that by Monday, then what's the next step as far as what's the next process?
What do you mean? Well, Tara will put some together, and then we'll send them out to you.
Okay.
Let you make comments on them. Okay. Now, and I will tell you, Mabel, when the speaker asked me to, co-chair this, and I I didn't need another committee to work on. But I do appreciate it because it is about women, and I thought that was a really good idea that a woman would be chairing this meeting. And I know why the other is a physician. That's why, he asked for it. But the objective was, Abel? Yes. The objective was of the committee study group to immediately find ways to save lives, immediately. And so that's why we focused so much on it, was how do we stop the bleeding? What do we do to stop preeclampsia? What do we do? And the data was showing, even though it is old, that those were the biggest categories where we needed to make the intervention quickest. And that things like suicide and that things like were not as many. Very important. And certainly in trying to stop those deaths, and this is just what I was told to move, was knowing that African American women were dying at a much larger rate than other women, 3 to 4 times more is what the national average says, that it was even more important that we try to find out what was making them die quicker. Were they hemorrhaging? Were they dying from strokes, from high blood pressure? Were they having preeclampsia more? So that we could try, like they say in nursing, to triage. You first triage people, and the sickest get the care, or the people with the most, the dead get the most. I mean, it's like on the battlefield. If they're going to die and there's no help for them, then the next ones, or think somebody take the worst hit and they can do something for them, and on down, and they triage people. And that's what the thing was, to find out what we could do, what was killing women, especially African American women, and what we could do to lower those numbers as fast as we could lower them so that we don't have the deaths. Working, and that is why we really didn't get into just discussing so, in depth was the socioeconomic and determinants that were causing African Americans to die at a higher rate. Those are very important, but I guess it's been like stop the bleeding first, and then we can tackle as a next thing these other things we're talking about. So I just want you to know why there was such an emphasis in the group, to know why there was such an emphasis on trying to stop the bleeding first. So that's what we were doing. So thank everybody for coming. We'll get these up. Carolyn, thank you very much for helping me put things in right words sometimes when I don't get them right. Thank you very much. And I appreciate everybody on the committee for being so involved. And I guess we go from here. Dr. Ellis, I can't thank you enough for taking time away from Grady. And I look forward to what you can tell us to do with your experience to do that. And certainly if people like Black Lives Matters, if there's something we can do right away. Black Mamas Matter, is that what it was?
I'll get it right to you.
Okay, that she'll get it to me, and if there's something that we can start to do right away. And I can tell you, I'm a big proponent of community support. They have found it helpful in so many communities on so many illnesses when nobody else can reach people to try to help themselves on all sorts of problems. People in a person's where they live and they know and go to church with can really make a difference in their lives. So I'm big. It may not, it may take a while to get for the levels, but I am a big proponent of that. So thank you very much. We are adjourned.